that you want to use during the treatment. Is it different if you perform an endodontic treatment with or without the magnification? Is it different if you perform your endodontic treatment with hot rotary files or reciprocation files? Is the success rate is different if you use a bioceramic sealers? This is all the technology that you will use during the treatment. And the last kind of factors is the restoration related factors. Is the coronal sealing have an impact on the success rates? Is the quality or the type of your restoration, the post-restoration, have an impact on the success rates? And the question that I want to ask you is, in your opinion, have technological advancements has improved the success rates of the endodontic treatments? It can be a tricky question, and to answer to this question, I want to show you this graphic. This is the success rates over the decades. And what we can see about the success rates over the decade, and if we looked at the success rates in 1963, what we can see on this part of this graphic is that the success rate is the same as what we can find today on the success rate. And you know, in 1963, they don't use the same instruments. They don't use the same technology as we use today. They don't have any rotary files. They only use hand files. They didn't have any bioceramic sealers. They didn't have any magnification. It's very strange that the success rate is the same as what we can find today. It's very surprising also. And let's talk about this study. On this study that made in French, they look at the French radiograph, and they look it at on 2001, and they calculate the percentage of treated teeth with apical periodontitis, and they calculate the percentage of inadequate treatments. And here is the percentage. They did the same study in 2009. And do you think that we have improved the quality of treatments? And here is the percentage. The percentage is the same. We didn't change the quality of our treatments. We didn't change the percentage of apical periodontitis on treated teeth. It's also surprising. And I'm pretty sure that we can find this kind of study all around the world. I'm pretty sure that we have the same problem all around the world. And this study is very amazing because the conclusion of the study said that the prevalence of apical periodontitis and the technical quality of root canal treatments in Belgium have not changed over the last 22 years, despite all the technology advancements and all the continuing education in the field. It's quite surprising for me. And this result is totally in accordance on what we can find on this review literature, because the only one evidence-based factors that we found that have an impact on the success rate is only to reach the working length, to shape at the working length with whatever instrument that we want, to disinfect at the working length with the respect of the apical area with whatever device you want, and to fill the root canal space with the length control with whatever material that you want. And all the other factors, we didn't prove it. We don't have the evidence base that have an impact on the success rate. It's quite surprising also. But I want to be aware of this kind of results because yes, it's true that the success rate didn't change over the decades. It's the same success rate over the decade. But there is a big difference. Today, we treat more teeth. With the technology, we can consider that endodontology is more affordable for all the practitioners. Before, the endodontics was only for the specialists. Today, we can make the endodontics more affordable for everyone with the technology. We save more teeth. That's true. We save more teeth. We also pushed the limits of the conservation of the teeth. We perform the vital treatments also. We perform retreatment. We perform the surgical retreatment. So we treat more teeth. And if we treat more teeth, we increase also the number of the success. But I'm pretty sure that maybe it's not possible to reach the 100% of success rates. I think it's impossible. So maybe our objectives, our aim in our clinics is try to be stable in our success rates or not decrease the success rate of the endodontic treatments. And to achieve these goals, we have to avoid any diagnostic errors. We have to avoid any treatment planning errors. We have to avoid any procedural errors. That's why I want to talk about you this night about the human and the organizational factors in the endodontic treatments. And you will see that the endodontic treatments is not only a matter of technique. You will see that the non-technical factors, the organization have also a big impact on your in our treatments. And this is what I want to share with you this night. So there is two big chapters in my presentation. The first one, I want to talk about the organization of the asepsis protocols in our clinics. I want to share with you about my protocol, but I think that maybe you know about this subject, but I want to share you some different points of view. And in the second part, I want to talk about you the management of the human factors. I don't know if it's okay about my English, if it's understandable. If you want, I talk more slowly. Ratanak, don't hesitate.
I think it's okay. I think it's okay.
I think it's okay. Okay.
Yeah.
Wait, because I don't have the view. Also, I have the view now. Nice. On the screen. Okay. I will talk about first one. I will talk about the organization of the asepsis protocol and the management of the human factors. And maybe we will make a little break between the two chapters. We will see together. So let's talk about the impact of the asepsis protocol in endodontics. So to talk about the asepsis protocol, we have to know the definition of the endodontic treatments given by Ostavik and Pitford. This is the endodontic treatment is the prevention and the treatment of apical periodontitis. That means we have to treat the apical periodontitis. We have to eliminate all the bacteria that are present inside the root canal. So we can go to this, we can achieve this goal by all the technology that you will use for the disinfection. It's important part. But the prevention of the apical periodontitis, it's to prevent any contamination during the root canal treatment. And this contamination of bacteria inside the root canal treatment can be done by the dentist or can be done by your dental assistants. So we have to be aware about the prevention of the apical periodontitis. We have to talk also about I think you know about it. It's about the healthcare associated infection. It's also known as the nosocomial or the hospital infection. It's an infection that occurs during the process of care in our clinic or in the healthcare services, which was not present or incubating at the time of admission. That means it's this type of infection can be done by the dentist or can be done by the dental assistants. And the asepsis is a preventing method that avoids any infectious diseases by preventing the introduction of microbes into the body. So healthcare associated infection has some relation with the asepsis protocols. And to introduce to these subjects of asepsis, we have to talk about this study made by Shannon Patel, who is an endodontist located in London. And what he wanted to show in the study, he wanted to calculate his success rates. And to perform this, what he did during his treatment, he used conventional treatment that we do today. That means he used rotary files. He did sonic activation. He did a warm vertical compaction. So all the traditional technology that we can have today. And this is his success rate. Sorry. So what we can see is that in his heal rate, it's about 87%. His healing rate is higher. That's normal, about 95%. But what we can see and what is interesting is that on the CBCT, his success rate is lower than on the 2D X-ray. But this is normal also because the CBCT have the ability to see more lesion than the 2D radiograph. That's normal to have a lower success rate than the 2D X-ray. But there is another important point that he wanted to mention about his study, is that after initial treatment and after retreatment of the teeth without lesion initially, so there is no lesion initially, about 16 to 17% of the teeth showed a lesion at 1 year on the CBCT. It's surprising, there is no lesion, and after his treatment, his conventional treatment, as we can do today, he saw a lesion at 1 year. It's quite surprising. So he wanted to wonder what are the cause of the apparition of the lesion, what are the source of the errors, and what he thought is that maybe he made some mistakes during his protocols. He made some mistakes about his organization. So he started to think about a potential nosocomial infection, about a potential microbe that he introduced during his treatment. So he started to rethink about his action during the treatment. He started to rethink about his environment during his treatment. And I always show the picture that I show you on the left side. This is a photo of that I took of one of my students when I was assistant professor. He was mixing cements on a plate that wasn't designed for the endodontic treatment, and it wasn't sterile plate, you know. So maybe he introduced during the operation some bacteria of the plate on his treatments. And you know, it's a student photo, but I think it's not his fault also. It's not even his fault because even in France, during the initial initial training of dentistry, we didn't talk about the organization. We talked a lot about the technical factors of endodontic treatment. We talk about training, rotary file, bioceramic. We talk about the disinfection, but we don't talk about the organization of endodontic treatment. We don't make an important point of the biological point of view of the endodontic treatments. And that's why I want to talk about these subjects of the nosocomial infection. And you will see that maybe it can be as important as the technical factors for the endodontic treatments, or maybe more important for the endodontic treatment. So after this introduction, we will how I can say, we will see together all the points of our treatment that we can improve about our organization, about our protocols to improve the asepsis protocol. And maybe you do of one of you perform this kind of protocol, I'm pretty sure, but I want to give you another point of view maybe, and it will be interesting to discuss with you about all the different points. So the first point, and I'm pretty sure that everybody in the room use the rubber dam. We are all okay with the use of the rubber dam, and we not only use the rubber dam for the asepsis reason. We also use the rubber dam for the safety reason, because the rubber dam protects the patients. The rubber dam protects also the dentist and protects the dental assistants, because we protect the cheek, the mouth, the tongue, the lips of the patients. So we have to use the rubber dam during the endodontic treatment. It's mandatory. But is it enough to use the rubber dam? I want to show you something on the picture on the right side. After the placement of the rubber dam, what you can see here and what you can see here also, this is the dental plaque of the patient. That means if we don't clean the dental plaque of the patient before the treatment, we can maybe introduce some bacteria of the plaque on the root canal treatment. So we have to clean all the plaque before to perform the endodontic treatments. But is it enough? Let's go further also. This study is interesting because I know that today it's not easy to prove that the rubber dam improve the success rate. It's not easy to have this kind of study. But what we can know today is that the success rate of endodontists and the success rate of the general practitioners is different. And the success rate, not the success rate, the rate of use of the rubber dam is very higher for the endodontist and is very low for the general practitioner. And what we can see is that the success rate goes in the same ways at the rate of use of the rubber dam. So maybe there is some correlation between the success rate and the rate of use of the rubber dam. But let's go further on the asepsis protocol. So we talk about effectively about the dental plaque that we have to clean, but I don't know if you, for example, if you use the same instruments to place the rubber dam, you know, this instrument was in contact with the patient's saliva, was in contact with the patient bloods, were in contact with the patient bacteria, the patient skin. And if we use the same instrument to perform the root canal treatment, maybe also we can introduce some bacteria inside the root canals. So that's why what we can suggest and what the authors suggest is that we have to separate the tray. We have to have two different trays. We need to have one tray for the anesthesia and the rubber placements, and we have to have different trays for the endodontic treatment, a sterile plate for the tray for the endodontic treatments to avoid any cross contamination between the instruments. It's an important point about this study. So once we place the rubber dam, and before to go to the root canal treatment, we all know that we have to remove all the defective and existing coronal restoration. We have to remove all the caries cavity before to go inside the root canal, because if we don't remove it, we can introduce some bacteria of the cavity of the caries inside the endodonts. So we have to clean it. And I don't know if you have this kind of material in the market in Cambodia, but I like to use the caries dye detectors because, in my opinion, it's an objective way to be sure to remove all the caries before to go inside the endodonts. And if it's needed, we have to perform an pre-endodontic reconstitution to retain the endodontic solution. And what is advisable to perform is not a temporary pre-endodontic reconstitution, but what is advisable to perform is to do an bonding pre-endodontic reconstitution. There is several reasons to perform an in bonding reconstitution before the endodontic treatment, because the main reason that they show on the study is that if we perform the coronal sealing, the dentin sealing after the endodontic treatment, the dentin is with by all the endodontic solution and all the endodontic cements. That's why is in the study they show that we have to perform an bonding protocol and pre-endodontic reconstitution with a bonding method before to perform the endodontic treatment to have a better resin dentin bond strength and to have a good reservoir of endodontic solution. So we talk about the pre-endodontic reconstitution, and I don't know if you looked closely on your rubber dam, on your gloves, after you remove all the cavity, after you removed all the coronal restoration, we saw a lot of debris, a lot of bacteria on your gloves, on your rubber dam. And if you don't clean the dental plaque, if you don't clean the debris on your rubber dam, it could be possible that you can introduce some bacteria inside the root canal. So that's why what is recommended to perform before to go inside the root canal, to go to root canal treatment, we have to perform a rubber dam disinfection. And you know the rubber dam is not sterile, it's a consumable. We have to disinfect the rubber dam. We have to disinfect the rubber dam before to go to the endodontic treatment. And a simple way to disinfect the rubber dam is to take a gauzes like this, a sterile gauzes, soaked with the hypochlorite solution that you use for your treatments, and to clean the rubber dam or the rubber dam before to introduce any files inside the root canal. So there is two big steps that we have to perform the rubber dam disinfection. It's after the rubber dam placement and after the crown and the post and the caries removal. So before the shaping step, and we have to do it in the second time before the obturation. And these steps, I'm not doing this, but I asked my assistant to perform the rubber dam disinfection. So we have to teach our team, our dental assistant, our dental nurse to perform to know about the asepsis protocol. And that's why the asepsis protocol is not only a dentist matters, it's also a team works. We have to teach all the protocols to our team. And also, let's go further in the asepsis protocol. You saw you see when you place the rubber dam, when you removed all the caries cavity, when you remove the crown, you have also contaminated gloves. You have a lot of blood on your glove. You have a lot of debris on your gloves. And if you touch the active parts of your file with the gloves, and if you introduce the hand file in the endodonts in the root canal, maybe you can introduce some microbe inside the root canal. So we have to rethink also our action during the root canal treatments. So maybe we have to change our glove several times during the treatment. And I like to show this study because what they did in this study, they tried to calculate the number of microbes on the glove during all the treatments if we don't change the gloves. And what we can see is that the number of microbes on the glove increase during the treatment. So our glove is very contaminated by the bacteria during the treatments. And what is funny to highlight of the study is that the main bacteria that is present in our gloves is not a bacteria that are present in the mouth, in the patient mouth. It's a bacteria that are present on the skin. It's in the skin of the patient, in our skin. And this bacteria is called Propionum bacterium acnes. It's a bacteria that are not present in the patient mouth. So this kind of bacteria that can be present in the root canal, it's a bacteria that the endodontist or the dentist or the dental assistant introduce inside the body. And this kind of bacteria is not only a root canal matters, because we can find the nosocomial infection in all the kind of surgery, in brain surgery, in spinal surgery, in breast surgery, and also inside the root canal. That's why we have to be aware about the nosocomial infection, the healthcare associated infection. So we have to rethink our action. We have to avoid to touch the active parts, our files with contaminated gloves during the treatment. So there is some, how I can say, the killer action that we need to avoid. And we need to learn some teeth-saving action to avoid any how I can say to avoid any mistake in the asepsis protocol. So we can precurve for hand file with the tweezers, and we have to take care if we touch the gutta perca with the hand. Maybe it's advisable to touch the gutta perca with a sterile gauze, sorry. So to summarize the changing gloves and the rubber dam disinfection, I ask to my assistant, and I perform also the rubber dam disinfection and the changing gloves after the rubber dam placement and after the crown and the post and carries removal. It's a teamwork. We all have to perform the change of the gloves. After the shaping step, after the disinfection and after any radiograph, also I asked to my assistant to disinfect the rubber dam and to change the glove, because during the radiograph, we remove the dental frame, and with the glove, we touch the patient's skin, we touch the saliva of the patient, we touch the mouse of the computer, we touch the X-ray button to activate the X-ray. So at the moment, we change the gloves and we disinfect the rubber dam. And then before the obturation, also, we change our gloves and we disinfect the rubber dam. So I like this graph because it summarizes our protocols about the asepsis. But let's go further of the protocols. As we know, we have to use sterile instrumentation for the endodontic treatment. It's mandatory to use sterile instrumentation for the endodontic treatments. We have to do it. But it can be strange because in the markets, if we see in the market, they sell us some files that are not sterile. So if it's not sterile, we have to put the non-sterile instruments on the tray, and we have to sterilize these non-sterile instruments. It's very important to avoid any contamination. I don't know if you know also, but the tips of the apex locators is also we have to sterilize also, because it can also a source of contamination. And I don't know if you know also, but in UK, in the United Kingdom, they have to use any rotary file in the single ways. That means that they have to use only disposable instrument. Even the reused instrument, they have to change for every patient, because they saw that it's impossible to clean perfectly the how I can say the shape of the instruments. So in their country, they have to use the instrument in the single ways. So after the shaping step, we have to adjust our gutta perca. But we know that the gutta perca, it's a consumable that we cannot sterilize. It's non-sterile consumable, the gutta perca. You might know it. So we have to disinfect the gutta perca before to adjust them, before to fill the root canal. And we have to search a way to disinfect the gutta perca, because it's a non-sterile consumable. And one way to disinfect the gutta perca is to place the gutta perca in the hypochlorite solution during 1 to 5 minutes. And the percentage of the solution could be the same percentage as the solution that you use for your endodontic treatments. So we have to avoid any introduction of bacteria present on the consumable to disinfect them. It would be very interesting to know what is the percentage of the sodium hypochlorite that you can find in your market. Don't hesitate to write in the comments, because I'm very interesting about this. But in France, in Europe, and I think it's about 2.5 to 3% of hypochlorite, of sodium hypochlorite. I know that in the USA is about is higher. It can go to 5.5 percentage. Yes. Yes, it would be very interesting to know the percentage of solution that you use in your country. Yeah. But there is another problem with the consumable, because if you use, if you use the same tweezers that you use for the endodontic treatment, if you use these tweezers to pick the consumable, if you pick the same tweezer to pick your consumable, it's possible you might contaminate your consumable with the patient bacteria. So what we can suggest to avoid any cross-contamination is to have two kind of tweezers in your trays. One sterilized tweezers to pick the consumable tools, all the consumable tools, and another tweezers to use during your treatment, to use for the calibration of your GP cones. This is the first thing. But there is another thing about the disinfection of the gutta perca. I don't know if you know it, but if you place too long your gutta perca in the hypochlorite solution, it can happen some crystallization of the sodium hypochlorite on the gutta perca. You can have some crystals. You don't see it, but we can find some crystals on the gutta perca some crystal on the gutta perca. I cannot tell you what the impact of the crystals on the success rate of your treatments, but we should, I think, remove all the crystal that we can find on the gutta perca. And one way to remove the crystals on the gutta perca is to use a gauzes soaked with saline solution to wipe the gutta perca, and then to dry the cones on the sterile gauzes. This is one way to remove all the crystals on the gutta perca. So after the disinfection of the endodont, after the gutta perca calibration, after the X-ray of the gutta perca to see if we are good or not, we have to dry the root canal. And here also there is a big problem, because there is two kinds of paper points that are sold in the markets. There is the sterile paper points, and there is the non-sterile paper points. And if you use the non-sterile paper points, also maybe you can damage your root canal treatment, because you take all the time that you need to disinfect the root canal. You use a lot of technology to disinfect the root canal, and if at the end you use a non-sterile paper points, you can damage your root canal treatment. That's why we have to use a sterile paper points. This point is very important, because I know that in every country they sell the non-sterile paper points. It's a, how I can say, it's a nonsense during the root canal treatment. So we have to be aware about this. Then we have to obturate the root canal, and I show you again this picture above the mixing pad for the endodontic cements, because if you mix your cements on the paper mixing pad, on the non-sterile plates like this, you can introduce bacteria of the paper mixing pad or of the non-sterile plates to your endodonts. That's why we have to use the sterile glass plates for the endodontic cements. This is a very important point that I want to highlight. And I know today a lot of dentists, even in France, and think it's the same all around the world, because I don't know what kind of cement do you use in your practice, but I know that the bioceramic cements is increasing on the use by the dentists. And I think it can be a good material, but there is a problem of this material because the injection tips that they sell us that they sell with the premix cements is not sterile. And you know, when you inject the cement with this injection tip that are not disinfect, you can also introduce microbes into the root canal. That's why it's recommended to also wipe the injection tip with gauzes, a sterile gauzes soaked with the sodium hypochlorite to disinfect. But I know there is some study that they sterilize this injection tip. So maybe it can be another possibility to sterilize the injection tip. So we have to rethink our environment. We have to rethink all the organization of our treatments. And you know, there is a lot of things to sterilize for your dental assistants. It's not easy to sterilize one by one. And what I'm doing and what a lot of endodontists does is to sterilize all the instruments in a big tray, in the big containers. I know maybe you perform, I think you all doing this, but this is a good way to be productive, effective during our treatment for your dental assistant, to be fast for the cleaning of and the sterilization of your instruments. So you can see on the right side my endo tray. So I place everything inside, and I have another tray for the rubber dam placements and anesthesia. It's a tray that I also use for the consultation. Yeah. So I have two trays as recommended. So after the root canal filling, I don't know what's your opinion about this, but I would be very interesting to know about it. But I think we have to perform a direct coronal sealing of the endodontic treatments. We have to avoid any temporary restoration, because any temporary restoration can be a change to have a leakage of your treatments. And today we have a lot of proof that the bonding coronal sealing is a good way to seal the endodonts. So I think it was able to perform the coronal sealing after the coronal obturation and avoid any provisional restoration. And you will see why. You will see why. And I have a question. You didn't need to answer, but I want to give you this question. I don't know how is your practice, but in your opinion, who is the most convenient clinician to perform the coronal restoration, the coronal sealing, at least? Is it your referral practitioner, if you're endodontist, or is it the endodontist, or is it the practitioner who performed the root canal treatments? And in my opinion, the most appropriate clinician is the endodontist. And I want to show you why I think the endodontist is the most convenient clinician to perform the coronal sealing. I like to show this study because they show that if we perform the coronal sealing without the rubber dam, and you know that you, as I mentioned at the beginning, the referral practitioner, the general practitioner don't often use the rubber dam, then the success rate of your root canal treatment, if the coronal sealing is done without the rubber dam, is lower if it's done with the rubber dam. This is a reason why, as an endodontist, we need, if we want to improve or to stay stable on the success rate, we have to perform a good coronal sealing, not only a canal obturation. And this study is very interesting also because they said that the conclusion of the study is that if the definitive restoration is made 1 week, less than 1 week after the root canal treatment, the success rate is very higher than the definitive if the definitive restoration is made more than 1 week after the root canal treatment. That means we have to perform as soon as possible the definitive restoration. And I like also to show you the study. It's an old study, but it's an important study because they show that the success rate is not only a matter of the quality of the root canal treatment. It's also a big is also a matter of the quality of the coronal restoration. We have to perform a good coronal restoration after the root canal treatment to ensure ensure a good success rate of the endodontic treatment. And another study that is very interesting, they show that if the teeth is restored with the crown more than 4 months after the root canal treatment, there is a big chance that the teeth can be extracted with the chance higher by 3. It's a lot. And the main reason of the failures of the endodontic treatments is not endodontic failures. The main reason of the failure of the endodontic treatments is due to the prosthetic reason. So that means the endodontic treatments, it's not only a matter of the endodontist. We need to have a good organization. We need to have a good communication with the referral practitioner, because I like to show the case that that I show you on the lower side. This is a case of my good friend Coris Courvechel in France, in Paris, and this case is very strange and funny at the same time, because the endodontic treatment is done in the good quality of way, but the referral practitioner wanted to place a post, a 2 posts, and you can see the post on the measure side is not on a good way, and you can see, and we can think that the survival rates, the success rate of these endodontic treatments is now lower than beginning. And that's why we have to handle a good communication with our referral practitioner. So I have a lot of question about my presentation, because if we rethink about our treatment, we have to rethink about the environment, we have to rethink our action. I want to ask you, where do endodontics begin and where do endodontics end? Who is the most who has to perform the crown and the post removal? Is it the endodontist? Is it the referral practitioner? Who has to perform the coronal sealing, the coronal restoration also, who has to perform it? Who has to perform the vital poop treatments also? This is,
of course.
there is a lot of, yeah. Don't hesitate. If you have a question, you can ask to me, or if I'm not understandable, you can stop me also. I will be happy to answer to your question as you want. So yes, I want to say that endodontics today, we cannot stop at the root canal operation. We need to have a lot of knowledge on the vital pulp treatment. We need to have some knowledge as an endodontist about the prosthetic the prosthetic about the prosthetic. We need to have some knowledge about the adhesive bonding protocol, because if we want to save as much as possible of the teeth, and sometimes the most difficult is not the endodontic treatment. The most difficult is to treat the deep caries, is to treat the cracks. And so we have, as an endodontist, to get a lot of knowledge about how to manage the deep caries, how to manage the deep margin elevation, how to manage the bonding protocol. It's not only a root canal matters. So let's talk back about the asepsis. I went too far, I think, about the organization. So we talk about the gloves, we talk about the consumable, we talk about the procedure during the endodontic treatments. I didn't talk about the surfaces that we have to clean between each patient. I didn't talk about the workwear that we have to wear during the endodontic treatment. We cannot use the same workwear every day. We have to change it because it can be a source of contamination. I didn't talk about the quality of the air and the water that you use to spray the tooth during the treatment, because it can be contaminated. So we have to check the quality of the air and the water on your clinic, in the units. So there is a lot of things that we have to check. And I want to show back this success rate that I show at the beginning of the authors that calculates his result of the endodontic treatments. And I want to show you now what his success rates when he tried to improve all the points that I mentioned at the beginning. And what we can see is that the simple way of the implementation of the improvement of the protocols has improved the success rate of his treatments after 8 years, 8 years later. So some little thing about the organization, the protocols, can have a big impact on your success rate. So that's why I wanted to share you all these points tonight. I don't know if it's okay for you. I finished my first part of my presentation. I don't know if you have any question about it. If it's okay for you, Ratanay, I don't know. I know it's very late for you this night.
I think it's okay. It's okay. You can.
I can go further. So
we can
okay.
have a bit break, and then
What?
you can
Yeah,
continue
I just take some
your
water
second.
first, and then I will go to the presentation.
Yeah. ចឹងបើសិនជាអ្នកទាំងអស់គ្នាមានសំណួរអាចសួរគាត់បានមុននឹងគាត់ចាប់ផ្ដើមsecond presentation របស់គាត់
I will change just my presentation. I go back.
Yeah, actually, I want to let you know about the concentration of sodium hypochlorite.
Yes.
Yeah, actually, mostly in Cambodia, the general dentist prefer 1% of concentration, but
1%, okay.
Yeah, but actually, my team or my college prefer 3% of sodium hypochlorite, but
Yes, like us. Yeah.
some also use full concentration, like 5.25% of sodium hypochlorite.
Okay.
Mm.
Okay, nice. Nice to know it. Thank you for this. And I had a question also about wait about yes, I wanted to know if there is some study about the success rates of the endodontic treatment in Cambodia. I don't know if you there is some study or not about the success rates of endodontic treatment in Cambodia.
No,
You don't
no.
think?
Yeah,
Okay.
uh,
It's not easy to perform this kind of study, I think. Yeah.
yeah,
Okay, I will go further on my presentation if it's okay for everyone.
yeah.
So I talk. Okay. So I'll talk about the organization of asepsis protocol. It's important to avoid any procedural errors during the treatments. And as you can see, it has a big impact on the endodontic treatment. And we have to keep in mind the biological objective of endodontic treatment. It's not only a technical point of view, it's a matters of non-technical point of view. And that's why now I want to talk about you with you the human factors management. So we will see together what's the impacts of the human factors in endodontics. And we can see in the literature the words of ergonomics, the cognitive ergonomics, when we want to talk about the human factors. And generally, we will talk about safety in endodontics. And you will see it's quite surprising also. I think if you have performed endodontic treatments, I'm pretty sure every one of us, 100 of endodontists, 100 of dentists who perform endodontic treatment, has one day break a file into the root canal space. I think everybody of us in the room has experienced this kind of feeling when we separate a file inside the root canal space. This is an endodontic adverse event, and we need to avoid this kind of adverse event during our treatments. And we can imagine this kind of adverse events can have an impact on the results of your endodontic treatments. But there is another kind of adverse events, and this time it's not a small adverse event because this kind of adverse events can have an impact on the patients, on the body of the patients. And I don't know if you have ever heard about the Nicolos syndrome. It's a big extrusion of calcium hydroxide outside the apex of the tooth. And this calcium hydroxide goes inside the nerves, the corners of the nerves, also inside the artery. So it can have a nerve damage, but it can also have the skin damage because the calcium hydroxide can cause the skin necrosis and can have the skin injury on the patient. This is a big injury, big adverse events. And hopefully we have some case reports on the literature to know this kind of case reports, because we know that we have to be aware of this kind of situation. And another situation, I don't know if you have ever heard about this study, about this article, because there is someone who died after a root canal treatment because this patient had an allergy with one component of the premixed calcium hydroxide cements. And then the patient died after the endodontic treatment. So we have to know the allergy of the patient before to perform any endodontic treatment. It's a non-common situation, but it's important to know, to read some case report to understand how this kind of situation can happen. When I talk about human factors, sometimes we can think that this kind of subject is not very proved in the literature. It's not very, there is not a lot of articles, but I'll let you search on PubMed and check the number of articles that we can find on human factors on 10 years only, and to compare the number of the results on the endodontic results on all the history of PubMed. And what we can see is that there is much more results on human factors than all the history of endodontics. That means this is a evidence-based subject. This is a proven subject, and we have to be aware about this kind of subjects. This study is very surprising because if one day if one day I need to get an emergency surgery, and if the surgery is made by a surgeon the day of his birthday, I have a mortality that can increase by 23%. It's very surprising. And they saw that the reason of the increase of mortality is due to the time pressure. The surgeon has some time pressure because he wants to celebrate his birthday. He wants to finish the day. He wants to go home to celebrate his birthday. So he has some time pressure. And that's why he has the mortality increased by 23%. It's very surprising. It's very surprising. That means the adverse events is not only technical factors. It can be human factors, non-technical factors. And what about dentistry? In the study, they show that every day we make at least 2 errors per day. Every day. And hopefully only 1% of them progress to an adverse event. And what we can read on this study is that the majority of the adverse events is not due to technical factors. It's not due to your knowledge. It's due to the organization. It's due to the non-technical factors. And what is surprising also is that all the number that I gave to you before is underestimated because the majority of the adverse events are not recorded. We don't record the adverse events. And so if we don't record it, we cannot report the adverse events. And I want to ask you one question of adverse events, because in dentistry, I'm pretty sure we don't have the culture of the reports. We don't record our adverse events. If I ask this question to many dentists, how many files do you separate in a year? I think that we don't know because we don't record our separate instrument. We don't record our adverse events, but you will see that it can be interesting to know what is our complication rates, because it's as important as our success rates. You will see. So to to avoid any mistake, to avoid any complication, the WHO has in big objective in the world to perform safe surgery. And to perform safe surgery, they introduce in several hospitals a checklist. A checklist is a simple sheet where you check if everything is okay before to go to another step. For example, we check if we have the right patients. We check if we treat the right tooth, if we don't miss anything before to go to another step of the treatments. So it's a simple thing. And then they introduce this checklist in a lot of hospitals all around the world, in different countries, not only rich country, but also different country in the world with different practitioners, with different philosophy, with different kind of health services in the world. And what we can see is that the simple way to introduce the checklist in hospital have a big impact on the death rate and on the complication rate. And as you can see, the death rate is lower than if we don't place the checklist. So when they saw that the checklist have a big impact on the complication rate, they introduced the checklist in all kind of surgery. But I want to ask you this question: what about safety in dentistry? What about safety in endodontics? And I want to talk about you with several points to try to avoid any mistake in our practice. Several organization in our practice to ensure safety during our treatments. So let's go together to talk about organization. So the first thing I want to talk is the pre-job briefing. It's a small talk that I have with my assistant every morning before to start the day. It's like 15 minutes where I comment every consultation, where I comment every treatment before I start the day. Because during this conversation with my dental assistant, we try to find any problem that we can have during the treatment, during the consultation, to avoid any problem. And for example, on this situation, it was a case where I treated tooth number 11, traumatic injury. There is a how I can say, the avulsion of the tooth, a traumatic avulsion. Then there is a replantation, but there is a root resorption after the replantation. And in this case, I wanted to fill all the root canal with putty bioceramic. It was a biodentin material. And this biodentin material, I don't often use it. I don't often use it. And when we don't use often a material, but sometimes you don't have this material, and sometimes this material can be expired. That's why in this situation, I asked my assistant before the treatments to check if we have the material and to check if we have some non-expired cements. Because if you don't have the material, you have to cancel the patient's appointment. So it can be embarrassing for the patient and for us also, for an economical point of view. So that's why the pre-job briefing is important for us. But we also commence all the consultation that we have during a day. I don't know if you have experienced this kind of situation when a patient comes to us, but the patient didn't know what the reason why he's coming for us. He didn't know exactly the number of the tooth. We didn't have the referral email. We don't have the patient email. We don't have the referral practitioner email. And this kind of situation is a big waste of time. And to avoid this kind of situation, what I asked to my secretary is to send an email to all the consultation, the first consultation of the patient. And in this email, we ask two things. The first, we ask to fill the medical questionnaire to prepare his visit in our clinic. Then I can know exactly who is the patient, what's happening to the patients. And the second thing that I ask to the patients is to sell any documents or any referral cover letters to us before the appointment. Then we can know exactly the reason of the consultation of the patient. And if the patients didn't answer or didn't fill the medical questionnaire, my secretary called the patients to give us any documents. And hopefully I have a software that I don't know if you have ever heard about this software. It's a software called Endodata. It's a software that I'm part of the I don't know how I can say I'm part of the scientific part of this software, and I'm very happy to use it because they change my way to my endodontic treatment. I will show you later how all the many features that I use with the treatment. So I use that I use with the software is for the consultation, for the medical questionnaire, but you will see that I will use it for a lot of reasons also. The second point, another point that is important and is mandatory is the cross control. Before I perform any irreversible action, before I remove a crown, before I perform the access cavity, I check if I treat the right tooth. I'm pretty sure we all know a story of someone, a dentist, who treats the wrong tooth. And this is the big adverse event. And I know that this kind of events, it's not a technical problem. It's non-technical problem. It's the stress, the lack of confidence, the lack of protocol, the lack of procedure. And to avoid treating the wrong tooth, what I have in my practice is that I make a cross control. Before the action, before I remove the crown, before I perform the access cavity, I said loudly that I'm treating the tooth 46 or any other tooth. And sometimes, yes, sometimes I make some mistake. And then my assistant tell me, okay, you're making a mistake. No, we are treating another tooth. But or the patient can also tell you that you're treating the wrong tooth because the patient is included in the treatment with the consultation. But it's not a problem if you make a mistake at this moment because you prevent, this is kind of prevention of any adverse events. So it's an important point and it's a mandatory point that I want to highlight. And another way to avoid to treat the wrong tooth is that my assistant is also responsible to make the punch on the rubber dam. So if she made the punch on the rubber dam, that means she know exactly what kind of tooth we are treating. And then we have a lot of cross control to avoid any wrong tooth treatments. And I want to show you these tips also, because today to avoid any adverse event of treating the wrong tooth, I like to perform pre-roll isolation and not a single isolation, because when I place a multiple isolation, I can count the number of the teeth under the rubber dam. And you know that when you place a single rubber dam, a single isolation on the lower incisors, and you know that all the lower incisors look the same, you have the big chance to treat the wrong tooth. That's why I think pre-roll isolation is a good way to prevent treating the wrong tooth. This one is also an important point. This is the teamwork. This is the crew resource management, we call it, because I let a lot of responsibility to my team. I let a lot of responsibility to my dental assistants, because you know, when you're about to find a canal, you're about to remove any separate instruments. We in my For me, I don't have the I don't know what time is it when I'm concentrate to this action. I don't know how much time I have left of the to remove a file. I don't know. I'm blocked to in a cube. I don't know what time is it, and my assistant have the role to tell me how much time I have left, and how much time I'm in. And then I can decide if I have to remove the broken file in another appointment, or I have to stop my action. But to summarize, I let a lot of responsibilities to my assistant, and then she's happy because she knows my dental assistant, my dental nurse is an important key in the endodontic treatment. It's not only a matter of the dentist. And she's happy about that because she has a lot of a good perception of her works. And then I want to talk about the 1 minute break. You know, when you finish the shaping step, as I said at the beginning, we have to change the tray of the shaping step to the obturation tray. And this changing tray can take a little bit time for the assistants. And so what I'm doing this time, I let my assistant to change the root canal obturation tray. I let the disinfection solution on the tooth, and I take a little break. It's not a full break because in this time I like to complete my medical reports on my software, the same software as I mentioned at the beginning, because I enter the working lane, I enter all the instrument that I use during the treatments, and during this time I'm efficient, I'm productive, because I will be ready also for the obturation, and my assistant is ready for the obturation. So I like to take a 1 minute break at this moment, because you know the root canal filling need very different material. It's very different from the shaping step. Though I prefer to have a little break at this moment. Then an important point during my treatment for my organization is the management of the task interruption, because we know that if someone disturb you during your treatments, if someone is talking to you during the treatment, you can have some disturbance in your concentration. You can have a decrease in your performance. So you can be more vulnerable. You can be, how I can say, you can make some mistake if someone talk to you in or not in the right moments. So we have to avoid this. We have to determine all the at-risk phases, and all the at-risk phases is different for everyone. And for me, my I want to be in the calm situation when I'm trying to find the root canal length, when I try to hear the apex locators, when I try to scoot the root canals. And if my secretary want to tell me something, and if she hear about the apex locators, she knows she cannot talk to me at this time. But if she wants to talk to me anyway, so she has to talk to my nurse, my dental nurse first, and then my dental nurse know exactly if it's an important message or not. If it's not an important message, my secretary have to let a message on my desk, and she know that I will answer later about his message. So this is how I manage all the task interruption. So we have to determine all the risky phase during the treatments, and we have to share to all the colleague, all your colleague in your office. Then there is the situation of no-go. The no-go situation. I don't know if you have ever heard about the no-go. This is the situation when you didn't check all the, how I can say, you didn't validate all the thing on your checklist before to go to another step. For example, when you about to fill your root canal, but your root canal is still bleeding, we know that we cannot fill the root canal space when it's bleeding. It's not possible. We have to stop. We have to do something else. And on this situation also, this is a case in this is the case where my best friend and colleague said that she wanted that I treat this lower molars, because she said there is an abscess on this lower molars, and she said she want I perform it quickly, because the patient want to go to holiday, and so she don't want me to perform through consultation. She want a direct treatment, so I blocked the 2 hours treatment for the patient. The patient accept the price of the root canal treatments, and when I open the tooth, I see that the pulp is vital. I see the pulp is normal, and in this situation, we should not perform the root canal treatment. We have to perform the vital pulp treatments. So in this situation, we cannot go to the endodontic treatments. And then there is this situation also. This is the situation where my colleague also wants me to perform an direct treatment of these premolars without initial consultation. And so I blocked the 2 hours treatments. The patient accept the price of the endodontic treatments. The patient already booked all the treatment with my general practitioner to perform the new crown on the roots on this tooth. And when I saw the patient for the treatments, I removed very fastly the post of the root of the treatment. And what I see very fast is that there is cracks on the roots. That means the prognosis of the root when there is a crack is very low. But I cannot tell it's not possible to tell to the patients because there is a rubber dam on the patients. And, it's not possible to explain that the prognosis is not good if we perform the treatments. But sometimes when your patient wants you to perform a single visit, treatments, when the patients live very far of your office, when you're pressed by the referral practitioner because he wants you to perform a single visit treatment because he wants to perform the crown, and when you're pressed by the time, when you're pressed by the money also, because if we have to perform an extraction, it's not the same thing that if we perform an endodontic treatment. And sometimes, yes, we perform the root canal treatment even if it's not desired. And this is in this situation that we can have a lot of incidents. And when we have an adverse event, when we have an incident, we have to know the source of the errors. We have to make a debriefing because we have to avoid any of this situation in the future. We have to avoid any adverse event. So we have to perform a debriefing. And there is a lot of source of errors. There is, as I said, the external pressure by the patient who want you to perform a single visit. The pressure from your colleagues also want you to perform as fast as possible of the treatments. You can have the internal pressure about the stress, the tiredness. You can have the lack of confidence, the lack of protocol, the lack of procedure. You can have also the lack of equipments, a malfunction of your equipments, a lot of source of errors. And there is something I made 2 years ago because I asked to a group of endodontists. I asked to a group of endodontists to remind any adverse events that they have, the last adverse event that they had. And I asked them what was the source, what was the cause of the errors at this time. And the main reason of the errors was the time pressure. It's very interesting. And I asked also to another group of endodontists, what was the source of errors? And we have the same results. The time pressure is the most common cause of adverse events. So we have to manage the time in our practice. And this result is totally in accordance that in what we can find in the literature, because when we ask to the dentist, to a general practitioner, to a hospital practitioner, to a specialist practitioner, what do you think are the most common source of errors? The time pressure is the main cause of errors. It's like the birthday at the beginning. It is the main course. So we have to manage the time of the treatments during in our office. So we saw together what kind of source that we can find to analyze any errors, but it's not enough because we need to count, as I said at the beginning, we need to count how many errors that we made in the year in our practice, because if we don't count it, we cannot know exactly our performance during the treatment. So we have to record our incidents. We need a register of data, the data of adverse events. This is the same way on how we calculate the success rate. We can calculate also the complication rates. And to introduce about the register, I want to talk about this register that is in England. This is the never events register. A never events, it's an event that should not happen to a practitioner. It's like treating the wrong patient, treating the wrong breast, treating the wrong here. And when it's an never event, but there is that some never event that can occur in a year. And in this register, they record the number of never events in a year in the medicine never events. So if, for example, there is the wrong side incision of your tooth, the wrong I don't know, the wrong patient or the wrong breast surgery, and the number is about 1 to 10. And when you go further on the never even list, what we can see is that the wrong tooth or the wrong teeth removed, there is the number of 42. That means in dentistry, we don't have this safety culture. We need to improve our culture of the security. In my so far is my knowledge, so far as I know, I'm not sure that in dentistry, in endodontics, we have this kind of register. We don't have this kind of lists of the number of complication. And what we have in France, for example, we have some survey. This is a survey made by the professor Alexis Gaudin. He's the president of the French Society of Endodontics, and he made a survey with students, Hugo Billy, and he asked to many endodontists and many general practitioners who perform the endodontics. They don't ask how many complications do they have in a year, but they ask if they have at least 5 separation in a year, at least 1 underfilling in the year, at least 1 any other complication on the year. And if they have only at least 1, they have to check to fill yes to the survey. And let's check together to the percentage of the answer, because it's very surprising. And what we can see is that only 73% of the endodontists say that they have at least 5 separation in a year. At least they said only 50% of endodontists have at least 1 underfilling in a year. At least 50%, also half of endodontists have at least 1 ledge or canal transportation in a year. And when I see all the number, I think with the survey, and the problem of the survey is that the number are all underestimated. It's not the right number, because when I ask you, like at the beginning, how many 5 separation do you have in a year? We cannot count. We cannot know. It's difficult to say about it. And that means we have to record all the adverse events. And thanks to my software, we can record all the complication. You can see on the right side here, what we can see is that when I complete my medical reports, when I complete my medical, my medical reports, I report the working length or the technologies that I use during the treatment, but I also record all the adverse events, all the complication. So I can report any blockage, any fire separation, any extrusion of hypochlorite, any bleeding. And in this situation, I record all the fractured instruments in 1 year of practice, and I can say what kind of instruments did I separate during the treatments, and what was the outcome. Then I can calculate the success rate of the treatment if there is a separate instrument. You can say it can be powerful to know the success rate after complication. And this is what we did on this on with this endodontist. We record all the complication in a year, and for this endodontist in the private practice, he had more than 300 non-surgical root canal treatments in a year. And what we reported is that there is 15 complication, and there is 3 rotary file separation that he retrieved, 2 separate rotary file that he was blocked, and one manual file that he could bypass. But what is interesting is not the number, but it's maybe to calculate the incidence, the rate of the incidence of complication, and to compare this complication to the literature. Because if you have a higher incidence of complication than the literature, that means the problem is maybe not the file that you use. The problem is maybe the dentist who used the file. That's why it's interesting to know exactly the incidence of the file separation and to compare it with the literature. And what we can see with these operators is that his incidence of rotary files is lower than the literature, but the incidence of the manual file separation is a little bit higher than the literature. That means he has maybe to be aware on the way he uses his manual files. It's very interesting. But would you like to know what can happen not in 1 year, but how many files do you separate in the career, in the 5 years career or 10 years analysis? And this is what we have done with these operators. I like to show this graphic because this is a 10 years analysis of fractured instruments in a single endodontist practice. And as far as my knowledge goes, I'm not sure that we found this kind of graphic in the literature. And I'm very proud to show you that, because let's comment together. So this is a cumulative number of fractured instruments that begins in 2014 and ends in 2024. So what we can see is that the cumulative fractured instruments decrease after the years. It's sure because after the time we gain some experience. We have some experience. We know the file, so we can prevent the file separation due to experience. The second thing what we can see is that in 2021 there was the COVID period, and there is a stop on the file separation. That's normal also. But what we can see after, this practitioner decide to work less. He decide to work half of the day less than before. So that means that if we work less, we have less complication. That's normal also. But the most important point that I want to show you about the cumulative fractured instruments is this. Is all the circle that I highlight. That means when there is when one instrument fractures, often several instruments fracture in succession. You know, that means when there is a instrument fracture, it can happen in some period in a year, maybe before the holidays, before any summer. I don't know, but there is in a period there is certainly time in the year that fractured instrument occur more oftenly. And if it's break more frequently in some period of the year, that means there is some organizational and human factors that we need to understand. And this is what I'm trying to understand now with my colleague, to is try to understand what can be the human factors or the organization factors that are responsible for the fractured instruments. Maybe we fracture more instruments before the launch. Maybe we fracture more instruments the day of our birthday, maybe. So we try to understand this, and I will be happy to share all my results. This is also the graphic that I will show during the endodontic congress in in Paris next week. So I talk a lot about the organization, the protocols. I'm sorry for those who wanted some technical, how I can say, the technical radiograph and technical part of endodontics. I wanted to talk about the non-technical parts of endodontics. So as you can see, and I hope I succeed to show you that the quality and safety are related. We have to keep in mind the biological objective in endodontics. It's not only for the dentist, not only for the dental assistant, but also for all the postgraduate dentists and undergraduate dentists, because we are too focused on the technical point of view. And the endodontic success is not only a matter of technical factors. There is a key point on organization, protocols, communication, and sure, we have to manage the time. We don't have to work. We don't have to take don't have to take too much time, but we have to know ourselves the right time to perform the right treatments for the right patients in the good quality of care. And I want to show you my colleague that I work a lot on this subject, that I make a lot of conference about the quality, the safety. This is only a small part of the quality, because we have a big subject about the quality approach, the quality improvements, about the statistic in our practice, about the success rates, about our own practice. And thanks to the software, we can do a lot of things. We can know our success rate, and it's important to know the success rate. If we want to improve our treatment, it's important to know the success rate also for the politics of the country, because endodontics is so often underestimated, and we have to prove that endodontics is as good as implants. And we have a lot of market in implants, but not for the endodontics. So I think if we have the data, the register of data, as I said, we can prove a lot of things about the endodontics, and we can how I can say, we can give to the endodontics the place that it can have. It's a good specialty, and we can save a lot of teeth with the endodontics. And this is my last word. I will thank everybody to listen to me. I know it's very late for you. It's almost maybe 11 o'clock, if I'm not wrong, or 10 o'clock. And thank you very much for this valuable time that you give to me for this session.
Okay, thank you for your good presentation, Dr. Xie. And take home message from me. So
Yeah.
yeah, do not perform endodontic on your birthday.
No, what I suggest to you all, is to not work the day of your birthday and do not work tomorrow, the day after your birthday.
Yeah.
It's not a good idea.
Yeah.
Yes,
Okay.
this is one thing that you all should do also.
Yeah.
If you have a question, you can. I will be very happy to try to answer, and I'm open to the question now.
អូខេបើសិនជាអ្នកនរគ្នាមានសំណួរអាច drop នៅក្នុង message ឬក៏បើក unmute ហើយសួរគាត់បាន
Thank Dr.
I saw a
Xiao.
good. Yes.
So a question, and I would like to say thank you for your nice presentation and very interesting topic and detail about how to ensure the quality and safety in endodontic. Well, I have two questions tonight about the IDS, or we can call immediate dentin sealing. Can you explain about your bonding protocol and which material that you use for lining and
Yes.
before your final restoration? And one more question is about the cementing protocol with your indirect restoration, like ceramic or
Okay.
lithium disilicate. Thank you.
Yes. Thank you for your interesting question. So when I remove the crown, I like to, as I said, I like to check if I remove all the caries with the caries dye detectors. I remove all the caries first in my mind, and I said that, okay, now I will place a little bit of caries dye detectors, and if there is still some red on the tooth, that means I'm not a good dentist, and I'm often surprised because there is also always some red colors on the dentin. So I like to use caries dye detectors. And to perform my bonding protocol, what I use exactly, I like to perform the sandblasting with the 50 micron of aluminum, oxide aluminum. Then I like to use the three-step bonding with the OptiBond FL. I don't know if you have ever heard about OptiBond FL. This is the three-step. We have to etch, then we have to place the primer, then the adhesive. I like to use this one, or I like to use universal adhesive with the Scotch Bond universal. I like this one also. Then my liners for the pre-endodontic reconstitution, for the non-vital tools, I like to use the injectable composites, the GC from GC, injectable composites, because it's a flowable composite. But I can with my small wait, I forgot the name. You know, the small instrument to design before to cure the composite. I like to design my flowable composite, and then I ask my assistant to cure the composite. Yeah, but for the vital pulp, I like to use the three-step bonding always, because I think it's proven that has a good outcome on the adhesive protocol. And I like to use I don't like to use the injectable composite as a liner, but I like to use a more flowable composite for the non-vital vital teeth, like the wait, I forgot the name. The Filtech composites, Filtech flow composite from 3M. Yes.
Sorry, is it the bulk fill or the bulk fill composite, right?
Yeah. Even when I perform the coronal sealing, this was your question, after the endodontic treatments.
Yes. For after
Yes.
and
So this was before the endodontic treatment, and after the endodontic treatment, I keep my pre-endodontic reconstitution. I try to clean as much as possible of the gutta perca on the wall of the cavity. I let only the gutta perca on the inlets, on the entry of the root canal. I use the burrs to eliminate, and then I used the sandblast. I sandblast the cavity, and then I perform my bonding protocol, and here I use the Optibond FL adhesive or the universal adhesive. Yes, and then I like to use when there is a crack. Then when there is a crack in the tooth, I like to use some fiber composite, like the EverX composite from GC. I think it's a power. It can be interesting in this situation. And then I fill the cavity with conventional composites. Yes. And then I let my referral practitioner to perform the preparation for the crown. And I ask my referral practitioner to not, I say on the report to not remove my composite. But sometimes there is some surprise. Yeah. Thank you for the question.
Thank you for your nice answer.
So, do you prefer single visit?
Most of time I perform single visits. The situation when I perform the multiple visits, first one is the biological point of view when there is an abscess. No, not yes, and when abscess and I cannot dry the canals. Yes, this is the big situation when I say no, I should not obturate the canals. Another reason is when I don't have the time. I don't have the time. So the biological reason is when I cannot dry the canals. Yes, but when I perform, I think most of the time is a single visit. Yes, but I know it can be a great discussion. It could be interesting to know because I know on the literature sometimes they don't find we have the good condition to obturate, they don't find any difference. But I would be very interesting to know the opinion of everyone. Yes. I don't know if you have any other question. I don't know if I was unstable during my presentation.
No, it's okay. It's okay. I think it's okay. So, one more question in the message. So,
Yes.
what is the best material for obturation in case of non-vital teeth?
On necrotic pulp.
Yeah, necrotic
When
pulp.
there is a
What is material, best material? Like sealer. What is the best sealer for obturation in necrotic part?
Oh, in my private practice, I said in the literature, they didn't find any difference on the outcome between bioceramic on resin-based sealers, between zinc oxide sealers. They don't find any difference about the sealers. In my practice, I like to use the bioceramic sealers, but as well as the resin-based cements. Yes, I like both, or also the zinc oxide cement, the ZUI. But I don't think there is better material than others. It's more an ergonomic point of view, I think.
How about the sealer resorption between xenoside-based sealer, resin-based sealer, and bioceramic sealers? How do you think?
It's strange because there is some time that we find, sometimes we cannot control because there is some case that we use the same cement, and on one case there is some disappearance, and some case there is not disappearance, and it can happen to the resin-based sealer as well as the other sealers. But what we can see is that some new bioceramic sealers have been delayed from the market because there is some disappearance of the cements over the time, and we saw that there is a lot of disappearance. That way that it has been removed, and it's sure that on the bioceramic sealers it's not new now because there is a lot, but we have to be aware to use the a good or well used in the literature about the bioceramic sealer. We have to not all the bioceramic sealer or good bioceramic sealer. Yes, you have to be aware about that. Yes, but I think that there is something that we cannot control. I think, in my opinion, we have to use some for the sealer. We have to use that the sealers have to set fastly to seal fast as possible the wood canal treatments. And I know that the zinc oxide sealers can set very fastly, but the bioceramic, sometimes we cannot control. They depend on the moisture in the wood canal. We cannot control a lot.
And one more question from
Yes.
me. So in the case of there is an extrusion of sealer or calcium hydroxide into the inferior alveolar nerve. So what is the management in your country in France? So
I think first of all we have to tell to the patients. I don't know, honestly. I don't know exactly what are the good management, but I think first of all we have to tell to the patient. Secondary, we have to. There is some. I saw some case reports. They gave some vitamin to the patients, vitamin C, I think, some anti-inflammatory also to help. But if it goes to the canals, it's too late. I think almost too late. Almost too late. So we have to avoid, and that's why when we are treating a lower 7, we have, or when we are treating
the
a 6 or 6 next to
upper.
sinus, we have to check a lot of time the walking length. That's why we have to check, and this is, we cannot perform the same. We have we have to perform a high quality, but when we're treating a 7, a lower 7, we have to check in mind. We have to place on the when you open the file of the patient, we have to have an order to say, be careful, there is the nerves. So we have to avoid this. But I don't really know exactly what the management of the extrusion of sealer on the canals. Yes, but for sure we have to prevent the patient. I saw some medication they gave to them about the vitamin, but I'm not sure about the effectiveness. Yes.
Yeah, I think the medication just the temporary management. It's not the permanent management of the extrusion.
Yes, true. Yes.
Yeah. So how about referring the patient to the surgeon? How do you see?
Maybe, yes.
Mm.
About the extrusion on the canals.
Yeah.
Yes,
yeah.
I think we have to go to the nurse or to the medicine department with the how I can say the nerve department of medicine. Yes, we have to refer to the physician.
Yes, because I saw there was few cases in Cambodia that there is an extrusion into the canal with the sealer. So I want to find the better way to deal with the extrusion between Cambodia and France.
Yeah, we have to take care, and now we have a lot of premix cement with the injection tips, and it can be dangerous if we don't control about it.
But most of the general dentists in Cambodia prefer lentil spirals to transfer the sealer into the canal. Yes, so
it's a good. Yeah, it's a good way. It's a good way. I think it's a good way if we can handle the lentulo, the spiral. Yes.
Doctor, I have one more question. For your daily endodontic practice, have you used the CBCT for every case or just selecting case?
No, only the key case, but sometimes I'm wondering that the CBCT is very, very, very useful for all the retreatments, I think. But I have a CBCT in my office, and